Good afternoon, Dr. Ardeshna.
Good afternoon, Toya, and thank you for having me.
Welcome to In Good Health.
A pleasure to be here.
Thank you so much. I'm really excited to talk with you today about epilepsy. You're an epileptologist.
Yes.
Can you tell me what that is?
So an epileptologist is a neurologist that specializes in the treatment of seizures and epilepsy. Epilepsy is recurrent seizures. So basically, I've had additional training in an epilepsy fellowship, which allows us to diagnose and manage seizures with the highest standard of care.
Okay. So where does the seizure live in the body? Like, what's the origin of it? Is it the brain or another organ that a seizure comes from?
So you're correct. So a seizure basically starts in the brain, and all seizures start there. It's an electrical phenomenon, so it's due to an electrical abnormality in the brain, but it can have many different causes, all the way from a prior head injury, to a stroke, to a brain bleed, to a brain tumor, to Alzheimer's disease. And actually, 33% of patients who have epilepsy or seizures don't have a known cause.
Okay, so it's not genetic in nature.
It can be, so there are certain portions which are, but what you said is actually very important, because a significant portion of epilepsy does not have to be genetic. So anyone could actually have their first seizure at any age. There does not even have to be a family history or a risk factor.
Wow. Okay, so now no risk factors. So not even in the brain, like if someone has some type of abnormality or are born with some form of disability or what have you, maybe not disability, but some type of abnormality in the brain, that wouldn't give them a predisposition for it? Or
No, that actually could. You are correct. So there are certain developmental abnormalities of the brain that does lead to a higher incidence or higher likelihood to develop epilepsy at any point in the lifetime. But if we took, say, 100 patients in this room who have epilepsy and seizures, and you and I kind of took a tally of them, 1/3 of them, we wouldn't find a specific cause.
I see. Okay.
And that's what makes my job even a little more difficult, let alone recognizing these. Yeah.
So now, what can a person do to avoid, prevent, or safeguard themselves in general?
So epilepsy and seizures, you can't necessarily prevent them. If, God forbid, you or I are going to develop them at some point, what's going to happen is going to happen, and some of that is part of the electrical workup of the brain. But you had asked, what could you do to minimize, if one occurs, any risk of injury or consequence? So we do have, we teach our patients when they come in, or make them aware about first aid for seizures. So in that sense, if someone is seizing here, to minimize their risk of injury, what we do is we try to lower them to the floor, turn them to their side, ideally their left side. We don't hold them or put anything in their mouth, because that could lead to injury either to the patient or to one of us who's trying to help.
I think that's what we all understood. I don't know how it got out there, but I remember a time in life where there was a story that you put a spoon in the person's mouth, or
that is correct, and that is still done, as much as I hate to say it, in places. Unfortunately, it's not the right thing to do. But of course, part of my job, and now that I've been here with you, both of us together, as well as other healthcare providers, our goal is to increase awareness of epilepsy and how to provide treatment for epilepsy in that emergency circumstance, the first aid. So yes, the basic is try to ease the patient to the ground, if possible, or to a chair, so that we minimize the risk of a fall, get any hazardous objects out of the way, don't hold them or don't put anything in their mouth, because of, again, the risk of injury both to them as well as to us who may be trying to help. And then you had asked, let's say I do have epilepsy or seizures, what can I do to the best of my ability to prevent it, to avoid a breakthrough seizure, as we call it? So the answer there is, obviously, the primary treatment for epilepsy is what we call anti-seizure medication. So one is taking the medication as prescribed, being compliant, and then ensuring that, as much as possible, the individual gets enough sleep, does not miss meals, minimizes stress, and infection is treated as promptly as possible, because it's really those things, along with others, but those big four things, that even in someone who is taking their medications faithfully, that can still trigger a breakthrough seizure.
So I've witnessed a person having a seizure.
Okay.
Is it possible to have seizures that are not epileptic in nature, or do they go together always?
You are correct. So there is a type of seizure, which is what is actually referred to as a non-epileptic seizure. That's how I would tell patients about it. It looks externally like an epileptic seizure, somewhat like as you're describing, but this is not caused by an electrical abnormality in the brain.
I'm aware that you have new equipment and technology that you're using to help people who are dealing with this. Can you tell us a little bit about it?
Sure. So McLaren Macomb, as part of McLaren Health System, has started a new subspecialty service line as part of their neurology service line, and that is basically specialized diagnostic and management for epilepsy and seizure patients. So that includes consultation with an epileptologist, such as myself. We have outpatient testing available, as well as the hallmark of the program is actually an epilepsy monitoring unit, or we refer to that as an EMU, and that is, it's a 2-bed unit inpatient that is actually dedicated for epilepsy patients. It contains specialized equipment such as 24-hour video monitoring as well as audio monitoring. So in this case, patients are brought in on an elective basis or pre-scheduled basis for a multiple night stay. And what we do there is just as we talked about with the EEG, but this is a much longer and more specialized EEG with audio and video. We record their EEG for multiple days, and in that case, our goal there is to diagnose seizures, determine the type of seizures, sometimes clarify the diagnosis when it's unclear, and then determine the optimal management plan. And in that unit, we have, as part of that, McLaren Macomb has specialized EEG technologists that monitor the patient 24/7. So I am one of that team of healthcare providers.
Okay.
And the purpose of that unit, the technology has been available for years. We are fortunate now locally here in Macomb County that McLaren Health now has it, and the first place that McLaren has it is McLaren Macomb, and they've designated that as the system's epilepsy hub. So when these patients come in, what we do is we actually try and provoke and record their seizures under these circumstances to help us, one, verify the diagnosis, clarify it, determine where their seizures are coming from, the type of seizure like you alluded to, and then determine their optimal management.
Wow, that's amazing. So in provoking it,
Yes.
Is it activity that you will have them do? Will you put them under stress, or what does that look like?
Yes, so it's actually, there's limited things we can do. Sometimes we wish we could do more, but again, safety is the first goal. What we do is when the patients come in, we slowly take them off their anti-seizure medications.
Okay.
And then, as you said, there are certain stressors, such as we do something called photic stimulation, which is flashing lights. Sometimes we sleep deprive them, which is a stressor. And it's a combination of these that we hope to record a seizure by, because it makes a seizure more likely to occur.
A person who has epilepsy, can they feel when a seizure is coming on? You know, I'm wondering if it impedes the quality of their life in any way.
So you made an excellent point. So there's two issues there. So some patients who have seizures or epilepsy do have what they refer to as a warning before it. So they may be able to feel something, and that's what we refer to as an aura, okay? But not everyone does. So again, just like every individual is different, to me, every patient with epilepsy is different, okay? And we have to make a unique management plan for them. And then you had asked about
The quality of life.
the quality of life. And so with that, there's really one thing that in my opinion, is the underlying treatment principle. So as an epileptologist, my goal for an individual with epilepsy or seizures is to get them to seizure freedom, be seizure free, and have no side effects.
I like
and
that,
to do
seizure
that,
freedom. Nice tagline
as soon
there.
as possible. And actually, it is actually the Mentera of the Epilepsy Foundation of the United States. That is the goal. And with that, to your point, so we want to achieve seizure freedom and have the patient have no side effects as soon as possible. The reason we want to be aggressive in this is because you want to prevent the long-term consequences of seizures, like memory loss or injuries. And then the key is that aggressive treatment allows them to have a quality and a productive life. So in fact, in my opinion, individuals with epilepsy can live a quality and productive life. In fact, that's the goal that we want them to have and have them achieve that as soon as possible. If we can't make them seizure free, still we want to control seizures as aggressively as possible to maintain that quality and productivity. And in fact, there is studies that show that the more aggressively you control seizures and the sooner you do, the better the quality and the productivity of that individual.
So you mentioned, we talked about how it's sometimes difficult to diagnose epilepsy and seizures.
Yes.
And why is that? You know, I know that in the public, from a public perspective, we are familiar with the grand mal seizure type of symptoms where the body shakes a lot and maybe the person loses consciousness or what have you. But what other symptoms should we be aware of?
So Toya, you are correct. Epilepsy is still a clinical diagnosis. And as we said, sometimes it's difficult to make and it's delayed because what we view as the most common, what the public views as the most common picture of a seizure is, as you said, an individual who falls, their body stiffens, they lose consciousness, they shake, and afterwards they're sleepy or lethargic. But there are actually many different types of seizures, some which are even more common than that. And that includes such things as confusion, memory loss, abnormal movements of the lips or the hands. We often call them picking movements or automatisms, changes in speech, or even hallucinations, or some combination of all these.
Wow.
Okay?
And would they occur at the same time? Is it something that you
So they
see a
would-
pattern of these things?
So they would occur in succession, you know, a
Okay.
couple of them. But this is actually, because it is often difficult to see these things or recognize them, in particular, they're often attributed, family members often attribute this, say, this is something else going on, it can't be this. So they're given a different diagnosis. Or because they're so subtle, you know, somewhat small, the diagnosis is delayed. So part of, as we said, why has this been going on for so long? Why is there a delay in diagnosis? Is this, and part of my job in increasing awareness is to actually increase the awareness of these other symptoms of seizures, which are equally as common, but this is how they can present.
Very good. Thank you.
Thank you, Toya.
Learn more at mclaren.org/Macomb epilepsy.